All right, welcome. This is Mrs. Ignacio and some motivated students that are joining me for discussions of maternity and complications in pregnancy. And right now we're looking at a visual aid that talks about the physiological changes in pregnancy. And Kathy just told us that it's going to be increasingly difficult for this patient to breathe. As we know, in the second and third trimester, this patient may have to sleep in a propped up position and the patient may experience dyspnea or difficulty breathing. So we also know that, that lightning can occur and the fetus will begin to descend into the pelvis. And at that point, the patient can breathe easier. Now, unfortunately, that doesn't take place until week 38 to 40. So the second and third trimester is really going to be very challenging for this patient. The patient also, respiratory wise, may also have experienced nasal stuffiness. If you've ever seen women that are very pregnant, you can see even their face has changed and their nose, you can just look at them and tell that their nose is stuffy because that goes with it. Now, one of the things that we have to look out for too is epistaxis, that is nosebleeds in our pregnant patient. Okay, and of course, this pregnant patient is going to be increasing their use of oxygen because they're not just breathing for themselves. Okay, let's talk about nutrition and GI. So, what's some of the things you think about for your pregnant patient changes that's happening?
They're going to require more nutrition because they're not eating just for one, they're eating for two. And so a lot of stuff they eat, the baby is actually going to take because the baby needs the nutrition.
Right. Okay. So yes, increased calorie intake. So, and one of the things that we look at is if there is nausea, of course, we're thinking dry crackers, making sure the patient has small, frequent meals throughout the day. Ginger is going to be really great for helping with that nausea. And with nausea, the patient wants to avoid those fried foods, things that have strong smells, avoiding spicy foods. They need to also assess their weight because that's going to be important to make sure that they have a normal weight gain. I know back in the day it was like, oh, you're eating for two, just eat whatever you want. But we now know that that is not really a true statement, right? So we don't want that patient to gain too much weight because then that increases their risk for complications like gestational diabetes. Okay, awesome. Okay, we also, when we think about not only nutrition, the increased calories, we think about folic acid and iron. Folic acid is a big thing when it comes to mom baby, and we think about folic acid, we think about it prevents neural tube defects. Okay, the other thing when we think about the GI system, we want to make sure this patient has enough fluids and fiber so they don't become constipated. That's going to be an important thing. Cardiovascular wise, we know that, wow, okay, the heart has to be working harder, and we have to look out for fainting or weakness as in our pregnant patient because of possible drops in their blood pressure. So the side-lying position is going to be best. We want to encourage that second and third trimester patient to sleep on their left side. They can't sleep in the supine position because of vena cava syndrome. We also have to teach the patient to look out for varicose veins, avoid prolonged sitting, prolonged standing, constrictive clothing, crossing their legs. They have to elevate their legs. All of those things are really important when we think about our pregnant patient. When we think about the urinary system, we think about that urinary frequency in the first and the third trimester is really the worst, right? And we also want to look for any signs of UTI. Now, we also can see leukorrhea, and that is actually a normal finding, right? And Kathy, you all probably already talked about that in class. Is that true?
I think so.
Okay, so I'm going to put it in the chat just to make sure. And so leukorrhea is a normal finding. And so for your GU, your I'm sorry, your genitourinary system, we should not be douching because that actually disturbs the normal flora of the vagina. Good hygiene is going to be important. Wearing peri pads. If the patient has any pruritus or that's itching, if they have a foul odor or a change in character of the leukorrhea, then they need to report it because we may think that, okay, that's probably an infection, right? Also Braxton Hicks, those are false labor. And so if the patient changes their position, that will possibly be relieved as well, okay? Braxton Hicks. Okay, let's take a look now. Integumentary. So, have you already touched on the mask of pregnancy?
Yeah, we did. That was in the like on the first exam we had.
Okay, fantastic. So you know about the integumentary changes, all of those, the stretch marks, spider nevi. Okay, good, good, good. All right, let's lastly talk about the breasts. And what are you familiar with when it comes to the breasts and colostrum?
We talked about that. We talked about the infection that can happen with the breast during breastfeeding. And that's part of the test that we're going to have, the exam we're going to have on Wednesday.
Oh, okay, great. So let's just pause there for a moment and just kind of talk it through, okay? So what you were describing, it sounds like mastitis, right?
Mhm.
So how do we prevent? Well, let's talk about what actually happens when the patient has mastitis. So it can be painful, and it's actually the clogging of the milk ducts. And so unfortunately or fortunately, when a patient has mastitis, they will have to continue to feed through it or pump their milk because that's the only real way to get the milk to flow, to get those plugged milk ducts to be relieved. Now, what the patient can do to prevent mastitis is if they desire not to breastfeed, they can use cabbage leaves over their breast to dry up their milk supply. If they do desire to continue to breastfeed, and for some reason they can't breastfeed, they don't have a good latch, or there's some reason that they can't breastfeed, I would encourage the patient to pump her breast milk or express the breast milk every 3 hours to prevent the engorgement that can lead to mastitis. So if the patient has mastitis, though, they can continue to breastfeed through it. Another thing that they can do is stand under the shower with hot water beating against their breast and hand express the milk. And they really have to knead it. Really, it's like dough to really get those knots out, to get those clogged ducts from being clogged. And so that's really, really important. With that, we want to talk about caring of the breasts and the nipples. I don't know if you learned about it in class already about lanolin and how effective that could be. Or did you learn about breast milk itself? Just put some of the breast milk around the nipple because that can actually heal it. Did you all talk
No,
about?
she didn't tell us about that. We didn't
Okay.
we didn't talk about that.
Okay, so yes, definitely, check in your book, but those are two things that are the big things that even when you're at clinical, if you have a chance to talk to the lactation consultant, they will tell you that as well, that the lanolin is really effective, but more so with breast milk. And breast milk, so this is kind of a quick sidebar. Breast milk is like a cure for everything. It's just really amazing how healing it can be. But going back to the textbook, when we think about the breasts and the changes that the patient is going through, colostrum is that liquid gold that's early on in the pregnancy, and that could be sometimes be available at as early as 16 weeks. Okay, so really important for breast care is, the nipples to make sure that they don't get dry and cracked, because if they become dry and cracked, that can increase the risk for infection. They do have the breast care, they have pads in case the patient may be leaking milk, because sometimes women have like an overabundance of milk and sometimes the milk just leaks out, and that could be embarrassing if you're, at work and then you have these wet spots on your shirt. And so that's just, something to teach your patients about breast care. That's really, really important. The other thing is when they have their next mammogram, if they're of age, that's going to be one of the things that they will ask, have you breastfed, or are you currently breastfeeding? Like, so those are important things to discuss and let the doctor know. Okay. um, okay, we're going to jump right into the complications of pregnancy, because I know that that's a big thing that you're looking at for your next test. And we will start with diabetes, because I think last time when we met, we spent a lot of time on the hypertensive kind of disorders, but we're going to start with your diabetes. So tell me, Kathy, what do you know about diabetes or gestational diabetes?
Well, you can have pre-gestational diabetes before you become pregnant, and then when you become pregnant, most of the time they will monitor it through finger sticks. They don't do A1Cs during pregnancy because it doesn't really give you a true picture. Actually, that's for like more of a chronic care kind of thing. The A1C is, but not for gestational diabetes for pregnant women. Let's see, what else do I know? In the, I think it's the second and third trimester, they may have to increase um the insulin if they're on insulin. It can cause birth defects. And what else? It makes the uterus weaker because of the diabetes, if the diabetes is not controlled. Let me think, what else do I know?
Okay, you know a lot. Okay. Okay, I like it. I like it a lot.
I just got to connect the dots. That's what's messing me up. I'll be not connecting.
Okay, not connecting the dots. Okay, well, I think based on what you're describing, I'm going to ask you a couple more questions, but I think we need to jump right into our case studies then, if that's the case. All right, so it sounds like you're familiar with gestational diabetes. Just want to mention a couple things. The contributing factors that can increase the patient's risk is obesity. If they're older, if they have they're older in age, if they have a family history of diabetes, if they have a previous delivery of an infant who was large or even stillborn. And I know that you know already hypoglycemia and hyperglycemia, the manifestations, right? Nervousness, if it's low, blurred vision, tingling of the mouth or extremities. If it's hyperglycemia, the patient will be thirsty. They'll have polydipsia, polyuria, polyphagia, right? You already mentioned about the blood, so that's good. And so they may actually monitor the patient's A1C, but I agree with you. The big thing is going to be their dailies. And so we know that they will have that 1 hour glucose tolerance test where they have 50 grams of a glucose load, or they can have the 3 hour glucose test if that 1 hour test does not go well, meaning that they have a blood glucose of 140 or greater. And so all the things that you said, the risks that can happen if the patient does have, issues controlling their blood glucose, they can have those congenital abnormalities, spontaneous abortions, macrosomia, which is a large baby. And whenever we have a large baby, we need to think about birth trauma. We also need to think about shoulder dystocia. Those are really important things to look out for. Okay, so that is with your diabetes. And we had Natasha that joined us. Natasha, welcome. Do you have any particular questions? We're looking at complications of pregnancy.
No, I was getting out my note cards that I did earlier. But as far as with the diabetes, can you go over you said the congenital abnormalities?
Yes, congenital anomalies, and I don't have any specifics. Let me see. So when we think congenital, it's from birth and
Oh,
anomaly.
like I meant the list that you were going over, the complications of having the diabetes during pregnancy.
Oh, okay. So the risk to newborn, if the mom has poor glucose control. So the congenital anomalies, they can have a spontaneous abortion, which is a miscarriage. They can have macrosomia, so that's your big babies. And now with the big baby, we're concerned about birth trauma. Okay, not only for the mom, but for the baby as well. So they could increase the risk of shoulder dystocia, especially if it's a vaginal delivery, and they can face death, and also hypoglycemia after birth. So here's a random story. My daughter was in the NICU, but when she was in the NICU, we had a baby that came in and he was huge. He was over 10 pounds. And so usually the NICU babies are like, 1.5 pounds, 2 pounds. They're rarely like 4 pounds. And so when they brought this big baby in, we're like, oh my goodness, why is he in the NICU? And it's because of the mom having uncontrolled, blood glucose during her pregnancy. So he was suffering from hypoglycemia, and he was also having difficulty respiratory wise. So that was really interesting to see. But that, is a possibility of a complication that could happen. Okay. Any other questions, Natasha?
No.
Okay. All right. So do you all know the difference between abruptio placentae and placenta previa?
The previa is painless,
Mm-hmm.
and it's let me remember, let me get it right. That one is a bright red
Yeah,
blood,
yes, that is correct.
and abrupta is the dark red, and it is very painful.
Yes. Okay. And when that happens, what are you thinking? What's like a priority thing in either one of those kinds of scenarios?
Hemorrhage and getting the baby out.
Okay, yes. And so you're right. And so this patient is hemorrhaging, so I know the vital signs are going to be important. And one of the priority things, like if this patient with vaginal bleeding, a pregnant patient comes in, I know I better have a patent IV, because I know that I'm going to have to either bolus fluids or I'm going to have a transfusion for this patient. The other thing, other than a patent IV, depending on how the question could be presented to you, if they have a patent IV, we've already done the bolus, we've already done the transfusion, especially if it's abruptio placentae, we may have to get ready for an emergency C-section. So, but that's not necessarily going to be the first thing that you do. The first thing that you're going to do is get a patent IV, because we have to start replacing those fluids, because this patient, when you see it in scenarios, they usually have like a really low blood pressure, and you want to prevent them from going into shock. That's going to be the big thing there. Okay. I feel like I'm going to stop sharing. Let me pull up this. I want to get this case study, and I think that would be a good use of the rest of our time. And I'm just closing. I have a lot of tabs from the last session, but I think that would be a really beneficial use of the time. So I will give you a choice. This is going to be a case study with 6 questions. This is NGN style. So we can do ectopic pregnancy, gestational diabetes, or postpartum hemorrhage, or preeclampsia. Which one would you choose?
Um, let's do the postpartum hemorrhage because I need to get those medications down. I
Okay.
that's seriously, the medications is what I think really screws me up.
Okay, gotcha. All right, let me get that ready.
And is Natasha okay with that? I mean, we could do another one if she wants.
Yeah, I'm okay with the one that you, yeah, the postpartum hemorrhage, because I need to be more familiar with the medications too.
Okay, let me bring that up.
Is the pre-gestational diabetes, is that like there's pre-gestational and then there's just gestational? Is that right?
Yes, pre-gestational diabetes, the patient actually had diabetes prior to pregnancy. And
Oh,
okay, and when we think gestation, that is the time when the patient is pregnant. And so, and then pre is before pregnancy. So if you think about it that way, um, that may be a good way to do it. All right.
okay.
Okay, I'm just trying to find postpartum. Okay, why can I not find this? Of course, I can't find it when I'm trying to look at it. Okay, give me 1 second here. Okay, and while I'm trying to find what I'm trying to find, I'm going to show you this maternity medication. Um, okay, so we'll start with this one. I'm going to share my screen again because I don't think I'm sharing it right now. And I think what Kathy wants to know is, okay, what are the medications that go with pregnancy, right? Is that true? Maternal. And I actually had a really great PDF that I only have the hard copy though. I got it offline. Let me see if I could find it again and share it with you because it actually has all the medications and the purpose and the patient teaching. It was such a great handout that I found. Excuse me. Okay, let me see if I could find it. Um, no, it's going to take me too long. I'm going to write this down. I'll have to send it to you all because it's going to take me a while. Um, okay, maternal, but it lists literally all the medications that you could be tested on. It was a really good find, medications. Okay, and so on the screen is oxytocin, pitocin. What do you know about that one?
I know oxytocin helps start, it can start labor. I
Mm-hmm.
mean, I know they give it for that. But they also use that like when the lady, I mean when the mom hemorrhage too, they can give Pitocin slash oxytocin
That's
during
right.
that hemorrhaging time. It's for some reason it's not sticking, and I don't know why. I mean, I remember like I made up a silly thing in my head, like mom hemorrhage continuous during pregnancy, and that's so I can remember that is magnesium sulfate, that hema I can't bait, I think the name of it is cytotec and pitocin oxytocin during postpartum hemorrhaging.
I think that medication has something to do with like some kind of constriction or something like that. So I know what you're talking about. I don't know what it is either though.
Yeah,
Okay,
I had to make up something to try to remember the first letter of each one of the medications so I wouldn't forget it, that I know that that goes with postpartum hemorrhage.
okay, got it. So I will tell you if the mom has postpartum hemorrhage, one of the things that you hopefully will remember is your methergin, and so that's going to help that uterus having atony because we want the uterus to become firm. So and I like this visual because here it is a uterus that says, I just delivered my baby, but I can't stop bleeding. So this is a great kind of visual, and it gives you the considerations, right? Monitoring that blood pressure, the pulse, the respiratory rate, that kind of thing. That's going to be really important when you think about it. Okay, so that one, is that one of the medications that you talked about in class?
And that's the one I keep forgetting.
Okay, so look at this picture. Look at this uterus. Look at this bleeding uterus, right? And think Methergin. The side effects, your hypertension, nausea, vomiting, headache, and we want to monitor those uterine contractions, okay? And it does work really fast, okay? So it says within 60 seconds IV or 10 minutes PO or IM. And that's actually very good, right? Because this
Yeah,
patient,
so with
uh-huh.
this one, is this the one that you cannot give if the mom has hypertension prior to being pregnant? Like, because
I don't know that offhand, but it would make sense. And I would say definitely double check in your book because one of the side effects is hypertension. Okay,
okay.
so if
Yes,
the, go ahead.
the video that I was watching from the maternal teacher the other day, she did say that, I know she said hemabate was contraindicated with asthma and methogen was contraindicated with hypertension.
Okay, perfect, perfect.
Okay, and that makes sense with this, if one of the side effects is hypertension. So,
Mhm.
and thank you for that clarification, Natasha, because I wasn't sure off the top of my head. So that's very helpful. Okay, and I'm not sure why I can't see these postpartum questions. Let me see. Okay, I was going to the wrong thing. Okay, great. Let me just quickly look at these other medications. Um, this, yes,
Sorry, the oxytocin picture, can you pull that up real quick
yes,
again?
of course.
Okay, thank you.
You're welcome. And remember, the oxytocin, pitocin is for inducing labor. Now we have the opposite, which are the tocolytics, which we try to have the patient remain pregnant. This is your patient that is at risk for preterm birth. And so we have these, and I like this picture because she's like, it's not my time. And so Kathy talked about making up like stories or little sayings. So this is one that will maybe help you remember your tocolytics. Again, we don't want this uterus to go into labor. Okay, we don't want these contractions. Okay. Okay. And so you have your NSAIDs, you have your nifedipine. Nifedipine is also used for gestational hypertension, your mag sulfate, what we just talked about, and then the terbutaline, which is rarely used, but it can be used. And then the other thing that goes with preterm labor is making sure that we're injecting the steroids because we're trying to get that surfactant production, because one of the things we know with preemies is they don't have that surfactant, and that is going to be very important when we talk about their respiratory function. Okay. All right. So in the chat, I put a link, and this is going to be the next generation question. So I figured out how to get this together. So let's go through it. I found this great resource. It's a case study with 6 next generation style NCLEX. So you have the link. You can totally do this on your own. Unfortunately, you won't have the answers. So we're going to try to go through it though. Okay, so I'm sharing my screen. You should see case study question number 1. So this patient is in the 4th stage of labor and is being cared for following a cesarean birth. So if you are not familiar with cesarean birth, this would be a good time, like not right now, but like as you're doing the question, like, in the future, if you're not familiar, look it up. understanding that with cesarean birth, that mom might not have milk production right away. We have to look at the site, the wound site, assess for lochias still. So there's some things that we have to, that are very specific for cesarean birth. So with this question, it says, click to highlight the findings that require immediate follow-up. Okay, so I'm going to let you all look at this, and you will tell me what you think requires immediate follow-up. Sorry, I'm opening too many windows. Okay, sorry about that. Okay.
Is it her blood pressure?
Okay, so you say blood pressure. Which blood pressure?
For 1645.
I'm going with the
And
airway.
Okay, so the
Airway.
airway. Okay, so the heart rate 115, and that's what? Okay, Kathy put some stuff in the chat. 89% oxygenation needs follow-up on room air. And let's see, airway. Let me see. I'm just trying to see what airway thing are you talking about, Jackie? Or
Well,
are you?
yeah, I seen the pulse oximeter is reading at 89%. And I don't know if her body's trying to compensate for that with the blood pressure and pulse. So I would first look at the airway.
Okay, awesome. And so, okay, so this is good. Okay, so far, you got the pulse ox. Okay, what about in the notes?
I ain't read
This,
that for her.
okay,
I put the blood loss.
okay, blood loss of 400 mLs.
Yeah, because she already had lost 850, and they most of the time with cesarean, the max they say the max is 500 mLs that they should lose. But she's done lost a total of almost 1250 mLs of blood. She
Yes.
quantitative blood loss. She lost 850, and then she lost 400. So altogether, she done lost 1250. We are replacing some of it with the lactated ringers at 250, but that's a lot.
Okay.
And the fundus being boggy, but I mean, I'm more worried about the blood loss and her vitals at 1645.
Okay, yes, I agree with you. Okay, anything else that requires further or immediate follow-up?
she is feeling dizzy.
And so painting this picture with the patient, what she's telling you, and coupled with the vital signs, what does that mean? What are these clinical cues?
I think she's going in the shop.
Okay, so I feel dizzy. And what else?
She's hemorrhaging.
Okay, and so based on this note, this description, what else requires immediate follow-up? Because you're absolutely correct with the vital signs. These all need immediate follow-up. The fact that she says
Her
dizzy. Go ahead.
her well, she just delivered the baby, right? But her umbilicus, no, I don't think that, because it's still within the same day, because her umbilicus is still 3 centimeters. It's still 3 centimeters above the umbilicus, and then it's a boggy one. So that doesn't seem like it's progressing the way that it should, maybe.
So I have a question. What did you say the oxytocin does again?
It causes contraction, so that should be helping her fundus to go back to its normal where it should be. It should help
a lot
it,
of
but it's
blood
not.
too.
Yeah, but it's not going back.
Got it.
Okay. Okay, so that's a great question, Jackie. And I want to go back to what Natasha said. So this patient just had a C-section. Okay, and so what do we expect, or what would we like her uterine fundus to feel like?
Fine.
Okay, what is the presentation of her fundus right now?
It's boggy. It's like mushy, and it's not supposed to be that way.
Okay, and so what this, her vital signs and a boggy uterus, what do you know? What does that tell you?
It's not a good sign. I can't remember what she called it, but it's not a good sign.
Is that
Okay,
it bleeding still?
yes, she is
Mhm.
hemorrhaging. Our patient is going into shock, right? So you all understood that from the vital signs, but I want to make sure that you're connecting what's happening with this patient. She said she's dizzy, she's pale, all the blood is draining out of her body. Okay, her uterus is, the fundus is boggy. So that tells us we have to perform that fundal massage. And it's 3 centimeters above the umbilicus. That is huge, right? We should not have that. It should be at the level of the umbilicus and then going down. Okay, so that position of the uterus is a cause for concern. The fact that it's midline is good, but the bogginess is really what concerns me, coupled with those vital signs. So when we talk about next generation, these clinical cues, you have to be able to connect these dots, knowing that, oh my gosh, my patient's blood pressure is on a downward trend. At 415, it was good. And then, 15 minutes later, whoa, it's going down. Her oxygen sats are going down. Her heart rate is going up. Then at 445, holy smokes, like this patient is really going downhill fast. So when you are assessing this chart, that's what you kind of have to be looking at and interpreting this information and recognize that, holy smokes, at 415, she had 90% oxygen, 97% oxygen. And then at 445, she's at 89%. I'm losing my patient. Okay. So does that kind of make sense when we, paint this picture and look at these vital signs over a period of time?
Yeah.
Yes, and
Yeah.
so these are the clinical cues that we're talking about. So that's what NCLEX is testing you on, okay? All right, let's go to the next one. All right, so the client is in the 4th stage of labor. All of that is the same. Let me see if I can make this smaller so I can fit all the stuff in, okay? All right, I'm gonna let in, we've got some med-surg students coming in, but they'll just hang tight for a minute. Okay, so this is another question, and I'm going to just remind you in case you're not familiar with how next generation is set up. You're going to have to make sure that you click all the tabs and get all the information, because you're going to see maybe in future questions, right? Because there's 6 questions per case study that, okay, maybe there's going to be a new lab value or something like that. Okay, med-surg folks, hang tight. We're still doing maternity, but I just let you in so you can listen until we're finished with our next generation case study. Okay, so for each finding, click to indicate if the finding is consistent with septic shock, cardiogenic shock, or hemorrhagic shock. Each finding may support more than one type of shock. Each column must have at least one option selected. So let's talk about this just in case you haven't seen this kind of question before. So you have to check for blood pressure. The blood pressure that this patient has, do I think it's indicating septic shock, or cardiogenic shock, or hemorrhagic shock? Or with her blood pressure, can it be all 3 conditions? Her heart rate, is that consistent with these conditions? The blood that she's lost, do I see that in a septic shock patient? Her skin coloration, right? Her dizziness. So you have to check which one it applies to, okay? Does anybody have any questions about how that question is being asked?
No.
Okay, I'm standing by to check the ones that you all tell me. So for blood pressure, Is it
I thi-
septic shock or all three, or which ones you think?
Cardiogenic
Yeah, I mean,
Okay,
no,
so
and
hemorrhagic.
hemorrhage.
okay, hemorrhaging. Okay, and the med surge folks, if you know the answer, you could chime in too, but this is a maternity one, but you can totally chime in also.
The heart rate can be in all three of those shocks.
Okay, so I'm gonna check all three. Okay,
The
what, go ahead, Kathy.
blood loss is hemorrhagic.
Okay,
The color can be in, and the color can be in all three of them too.
okay, she says all three. Okay,
And the dizziness is, I think, in cardiogenic and hemorrhagic. I'm not sure about the septic one for the dizziness.
mm-hmm. Okay, does anybody else want to chime in anything that they think should be selected or deselected for this?
Y'all help me out here because
Okay, and I'm going to be putting the rationale also in the chat for the first question. I did not do that right away. Okay, all right, so let's talk about this. Okay, and so this patient, we know that this patient is in trouble, right? That was something that we saw because of the vital signs going on a downward trend. And so let's take a look at the findings that we see with this patient. Her blood pressure dropping, that is actually all three kinds of shock. We can see that happening in all three kinds of shock. And if you're not 100% sure about these kinds of shock, that's okay. Just go back to your textbook, because this is also actually an important med surg concept, that how will my patient present if they are in various kinds of shock, okay? So based on this patient's dropping blood pressure, it could be all three kinds of shock. The heart rate elevated, yes, Kathy was right, all three kinds of shock. The blood loss, when we think about blood loss, this is definitely hemorrhagic shock. The patient is hemorrhaging. Okay, so that was really good. Skin coloration is actually cardiogenic and hemorrhagic shock. If your patient was in septic shock, they may have a particular rash that's over their torso and their extremities, and that's the septic kind of rash. So they won't have this paleness, okay? And then dizziness goes with all three kinds of shock. Okay, so med surg students, we're just wrapping up right now with mother baby folks. So just hang tight and you can answer questions if you want, but we're just wrapping up. Okay, for the mother baby folks or anybody, any questions on this NGN case study question number 2?
No.
No. Okay, so do you all see how the style of the question is progressing?
yes, ma'am.
Okay, great. Have you seen this before?
The style of it?
Yes.
No, I haven't seen it.
Okay, we've got to get more of these question styles out to you all then. Okay, because this is super important. Okay, all right. Case study. Say again?
I said, yeah, definitely, because you trumped me on this one.
Well, these are tough. Like I'm going through them and I'm like, oh man. So these are really tough. All right, so same patient. This is question number 3. Complete the following sentence by choosing from a list of options. The client is most likely experiencing septic shock, cardiogenic shock, hemorrhagic shock. What do you think?
Hemorrhagic.
Okay, and we know that because she's hemorrhaging. We're screaming from the rooftop. She's got a boggy uterus. Her vital signs are dropping. So her blood pressure is dropping. Heart rate's increasing. Okay, good job. And that is correct. Okay, as most evidenced by what?
Total blood loss.
Blood loss.
Yeah, Kathy called that right away. She's like, wait a minute, 500 plus the other 8? No, that's not right. Okay, great job. Anybody have any questions or comments on that one? Okay, so, and I'm putting the rationale in the chat. Okay, all right, let's go to the next question. Question 4. So same patient, right? Now we have to look at this. Select the orders from each of the categories the nurse should include in the plan. So each category may have more than one order. So are we going to massage the fundus, weigh the peri pads? So to you all tell me what you want to do for this patient.
Massage the fundus and weigh the peri pads for sure.
Give
Mm-hmm.
her some oxygen.
Mm-hmm.
You're gonna type in cross and do a H&H. I don't know about that GFR rate. I don't understand that test, so I'll have to look that one up.
I think that has to do with the kidneys.
Oh,
It
okay.
does. It does. It tells you your kidney health, right? Your GFR. And so for a normal, healthy person,
It's good to know.
so and you can totally look that up. That's a med surge kind of question, right? Med surge 2 actually. And so is this a kidney kind of scenario? Is that what we're focused on right now?
No, it's not.
Right. Okay, good. Okay, what about the medications?
I think the top one, the fluids, I think we need to give that. I'm not
Okay.
sure about the Rogam because it didn't say anything in there about she was RH, but they may give it. I don't know. I mean, I don't. Well, the
Okay.
baby was born healthy. I don't know if the blood crossed or not.
Yeah, I
'Cause
think
it
I would
didn't
rule
say
out
that.
the Rogram and penicillin.
Okay, because Rogam is going to be administered RH negative, RH
Yeah,
positive, right? But
yeah,
this is a postpartum hemorrhage
um,
scenario.
yeah.
So is
So
Rogam,
no.
I don't care about Rogam right now. I'm trying to save the
Mm-mm.
mom's life, right?
Yeah.
Pen,
So
and
Right.
penicillin would be for an infection, okay?
section.
And this is not an infection scenario, is it?
Uh-uh. But
Okay,
she is potential to an infection because of the cesarean, but we're not focusing on that.
right,
Um,
exactly. And so what about, you said the medication, Mr. Prostal?
yeah, I'm trying to remember what that is. Do you know what that one is, Jackie or Tasha? Because I don't.
So no, but let me tell you, I'm going to choose that one because of how it's written, and it sounds like something that would be in the cardio section. And I know she need blood and some circulation, so I'm going to choose that one. Don't even know what it is. I'm just looking at the ending.
Okay, so y'all mentioned this medication actually earlier. Cytotec is another name
Oh
for it.
yeah, and that will help with bleeding. It sure will.
Okay, yes. Okay, so you all got it. Okay, excellent. So all of those things that you selected are correct as far as for caring for this patient. Okay, so yes, yes, and yes. So in this scenario, we have identified that this is a postpartum hemorrhage scenario. We're going to massage that fundus, weigh those peripads, give her oxygen, right? And if you are not sure of the immediate actions on how to care for a postpartum patient, for sure look that up because you're going to see this again. You're definitely going to see this again. The type and cross is going to be important because I know I'm going to have to administer blood to this patient. She has lost so much blood already. She's going into hemorrhagic shock. The colloidal fluids, because we have to expand her volume, her fluid volume, because she has lost so much of it. And again, what you all mentioned about the misoprostol. So, okay, great job. All right, let's go to question 5. All right, so the nurse activates the postpartum hemorrhage protocol. Which 4 orders should the nurse implement first? So this is priority, and you all tell me which ones I should select.
Oxygen
The type and cross.
and massage the fundus and administer the, or no, the 500 milliliters. We're giving her fluids, yeah.
So what about that medicine, the cytotec, to help stop the bleeding? Do you think that should be in the top 4?
I think first you should get her stable enough as a priority before you start, before you have to like administer the medication?
Okay, so you all agree that these are the four, or do you want me to add something else?
I just think that medicine should be given. I don't. I mean, because if it stops bleeding, we're gonna give her the fluids. We're gonna give her the oxygen. You're gonna type. The lab is gonna come and do the typing screening anyway. Type across. Nurse wise, I don't know.
Okay,
I
so
don't know.
so this is a tough one. This is a tough one. And so this is a priority because these are all great things that you want to do. But if you have to choose the four, I'm going to tell you, you're definitely going to massage the fundus. You're definitely going to administer the misoprostol. Okay. You're definitely going to give her oxygen, and you're going to give her the 500 mLs of normal saline. They're not going to do the type and cross right now because we have to get her stabilized first. Okay, and we can, get them stabilized by giving saline until we can figure out, okay, what kind of blood that we need to give to the patient. Okay, so those are the four interventions that you would expect to give to this patient.
Chips up all over the bed. You gotta go to sleep.
Mhm. Okay, all right. So I'm just ask everybody, if you're not speaking, if you could just mute right now. Okay, let me see. Okay. All right. Any questions about this one on question 5? Okay, excellent. All right. So those are the 4 that are correct. All right. Last question. All right. So this is a little different because now you see the orders. There's updated notes. So just make sure that if you do have this kind of question, that you're looking at all the different tabs and you're looking at the updated information. For this, it's like highlighted in yellow so you can see it. But for some questions, it might be you have to click the tab to actually see the lab value. So don't let that let you miss information. Okay, so with this, we have new notes. 1650, postpartum hemorrhage protocol. 1655, massage implemented. The misoprostol is given rectally. Bolus fluids, oxygen, fundus is firm. Bleeding has ceased at 1705. So here's all the orders. So here's the questions. The nurse reassesses the client after implementation of the treatment plan. Complete the following sentence by choosing from the list of options. The nurse determines the client's status is improving, deteriorating, or unchanged.
Improvement.
Improving. Okay, excellent. The bleeding has ceased, right? The fundus is firm and it's at the umbilicus. That's what we want. Okay, good job. So the nurse should now continue monitoring the client, administer blood products, or request a second uterotonic.
Continue to monitor.
Yes, good job, Natasha. So yes, we're going to continue to monitor because she actually has stabilized. Something I want to make sure I didn't emphasize it, but at 1705, these are her vital signs. Okay, so whenever you get these kinds of questions, make sure that you're really looking at any updates. The vital signs are updated. She's at 93 on 10 liters, right? So she has stabilized. Okay. So that is correct. You will continue to monitor this patient. All right, I'm going to stop sharing and I'm going to talk to my mother baby folks. Any questions that you have?
With the
No,
threatened, oh, sorry, go ahead, Kathy.
no, I'm fine. Go ahead, Natasha.
With the trauma during pregnancy, is that something, because I know on my card I have just like what you would do if they were choking, and but that's all I had. I didn't know if that was something that we needed to actually like know or look up on the trauma during pregnancy, or was that something you were explaining when I came in?
No, I didn't really talk about trauma during pregnancy. So that sounds like to me like not just choking, but like a motor vehicle accident, that kind of thing.
Oh,
And
okay.
so whenever a patient has trauma during pregnancy, I'm always afraid of spontaneous abortion. And even at clinical, when I've had clinicals, mother baby, we've had some patients come in, they didn't have their seatbelt on and, they were in a car accident, they were, hit. We're always concerned about a spontaneous abortion. So that's probably, one of the things, I don't know if they mentioned that in class, but that's one of my major concerns. Now, of course, if there's trauma, we also have to look at, stabilizing the patient because they can have major lacerations, internal bleeding. So we want to make sure that we're looking at those vital signs because that will tell us, give us some signs if in case there is internal bleeding, but everything on the outside, there's no wounds or blood gushing out or anything like that. Okay. Um, Kathy, do you have anything to add from the trauma and pregnancy? Because I'm not exactly sure what else she talked about in your class.
The only thing I can, and Tasha and I are in two different classes, but
Okay.
my instructor had said she briefly touched on how they do CPR for a pregnant mom. She touched on that and about the choking, but when I listened to the review the other day, the lady didn't go over, the professor didn't go over that. So I'm not sure if that's actually gonna be on this exam or not, but I guess it's a catch-all, you don't know. Um,
Okay, well, I would definitely, I'm gonna look at that. Okay, I'm gonna look at that because again, car accidents, motor vehicle accident is what I think of when trauma during pregnancy. That also, we know that pregnant women are at increased risk for domestic violence. And then compression of the abdomen if they were to fall. So that's why your pregnant patient shouldn't be taking the steps because their center of gravity is off. They should be taking the elevator, those kinds of things. But I'm going to look up to see if there's anything else that I could share with you about trauma in pregnancy, because I think that is actually an important topic. Okay. And if one professor mentioned it, it's probably going to be something that you see later on.